are not super not super happy with me today.
All
So
right.
apologies for taking so
We
long.
should be officially recording now. So
Fantastic. Thank you so much. So welcome. We've started our recording. Our goal always is to get our slides, the recording, and any other materials up to our SUD 1115 waiver website. There is a sidebar to the left that is labeled provider resources, and we are doing that as quickly as possible every time that we can after these meetings. We recognize that we don't have last month's up yet, but we are working on getting that posted. I'm going to go ahead and drop into the chat the link to that page. So keep an eye on that page. That's where we post all of our announcements, our memos, any meetings that we're having. And we should have this particular recording and last month's recording with the slide decks up very, very soon. This is our third official installment of the Medicaid Fee-for-Service Substance Use Disorder, or SUD team's technical assistance meetings. We started this cadence, obviously, 2 months ago. This is our third month, and we're super jazzed to continue to explore the format and figure out better ways to get support to all y'all. We, in our adventures with David last month, who kindly came and gave an amazing integrated co-occurring disorders presentation, or ICOD, not the fish, as David likes to say, presentation. We recognized that we needed a little bit more time when we have either special guests or special particular trainings on things that really interest you in particular. So we've actually expanded this meeting to be an hour and a half, but we also want to recognize that we may not use that hour and a half on days kind of like today, where we don't have a special speaker, or we may have maybe less to talk about. But just so you're aware of that, we do have an hour and a half, but we may actually finish up early. So moving on forward, additionally, we want to remind folks that our general mailbox is SUD waiver at odhsoha.oregon.gov for any of your SUD policy or ASAM questions. And any and all billing questions are to be submitted to medicaid.programs at odhsoha.oregon.gov. And that is a lot of letters to say out loud, which is why we have them on screen and why they'll be posted with our slides on our website. So there also is our fee-for-service provider services number here on screen for your use. So those are resources for you at any time that you need it. So I'm going to go ahead and introduce our team here today. I am Jennifer Poor. I use she, her pronouns. I am the Systems of Care and Coordinated Supports Analyst for the Medicaid Fee-for-Service Behavioral Health team. And I don't know if Sabrina is here or not as of
I
yet.
don't think so.
Okay. So we're missing Sabrina, but that's okay. We hope that she's well. I will hand it over to Liz instead.
Good afternoon. I am Liz Lorkey. I am the Substance Use Disorder Program Analyst here in the Medicaid Behavioral Health Policy Unit. So I am providing support for technical assistance, and also I maintain the behavioral health fee schedule. So I handle a lot of the questions that come our way about that as well. And just excited to be here and able to talk about some of the questions that have been coming through and some of the updates that are happening and all of that. So excited to get going.
Yeah, thank you, Liz. Okay, so it wouldn't be a meeting without an agenda. So we'll first review a couple of general announcements together. And for those of you who have been to these sessions before, you will find this redundant. And apologies for that. The repetitiveness is to ensure that our newcomers get the information as well. And then next, we'll take a look at the different distribution lists that you can sign up for to get information regarding meetings like these and where you can find provider resources. We've been really playing around with all of the different ways to communicate with all of you. And we want to make sure that no matter what avenue we use, that you're staying up to date and that you have access to all the things that we're trying to put out there to support, and or access to the ways that you can give us feedback. Like, hey, Jen, Liz, this is working, this is not. We want that feedback and we want to hear what is really, really supporting you, what is not. After that, Liz will go ahead and review some of the replies to prior sessions, technical assistance questions. She'll also talk a little bit about any reminders she might have and provide any other updates. And then we'll open it up for time for questions and answers. And just know that if we don't have an answer to a question, we will triage that and look to answer any of those outstanding inquiries offline. All right. So on to our announcements. Since we've come on board to our roles, we've been doing our very best to improve collaboration and communication around the behavioral health fee schedule change processes. We launched a new tracking tool that helps us better manage and respond to any fee schedule changes or fee schedule change requests. So if you come on board to us and say, hey, like, why don't we use this code, or I have a need to use that code, we have a process for that now. And this gives us clearer visibility into what's been submitted to us and where each request is in our processes. We are also following a more structured step-by-step process to make sure that everything is transparent and consistent. Our goal really is for everyone, internally and externally, to understand how decisions are made and how they move from the request to the actual final action. So a major focus that we're having is strengthening collaboration and communication with our external partners who are impacted directly by these changes. And as part of that, we're trying our best to build in opportunities to review memos or training materials and draft updates when they're relevant. We're also meeting with folks who have ideas or suggestions for any of these sessions or any other sessions that they think would be interesting or pertain to their work. So feel free to reach out with any of that or any requests to meet with us as you are rolling around how we can better support you as you practice. So we really want to ensure that we're catching issues sooner rather than later. And we want to thank all of you here because in these few sessions, we have gotten feedback that have led to changes that are positive, or we've found things that weren't correct and need to be corrected because of your outreach and voice. So please continue to do that. And we really want to work towards that strong alignment. So the right decision makers and the folks that are doing the work are engaged before any of our changes are finalized or we make any decisions. So in close to this slide, and I know it's kind of wordy, but we really feel passionate about this. We're committed to providing regular updates to our external partners about any and all fee schedule update changes and timelines, so no one's left guessing about what's coming next. All right, so that was our first announcement. Our second announcement, we're also really excited and jazzed about. We're extremely pleased to announce the development of our new behavioral health billing guide. We actually had our first kickoff meeting last week, and it went really well. We've started to better develop our approach, and we know our schedule of how things are going to roll out now, and we're going to start working on the guide itself. So that's super amazing and exciting. The guide will include several key components. One will be easy to use one-pagers on billing codes. We'll have licensing and certification guidelines. We're aiming to have provider enrollment and service information and further details on prior authorization requirements. And remember, this is for all of behavioral health. It's not specific to SUD, but it will have the SUD component to it. We're also planning meaningful community engagement throughout the project. This will help us gather input directly from all of y'all and users in general and ensure that the final guide is accessible, clear, and responsive to the needs of the field. Now, our estimated timeline for this is 12 months, and we will continue to share any developments and opportunities to engage as this moves forward. Another announcement is in regards to our transition to the ASAM 4th edition. Our compliance timeline was extended to July 1st, 2027. This extension gives time for us to be able to get the adolescent version of the ASAM 4th edition criteria, and it also supports a smoother transition process for the providers. In terms of implementation, OAR updates and additional support resources are coming soon. We will also be offering opportunities for community engagement for ASAM. So I think y'all are going to get to know us pretty well throughout all these different opportunities that we are offering. OHA's licensing and certification unit will be extending all previously approved ASAM levels of care, so they'll match your renewal period. It's important to note that you do still need to maintain licensure or certification for each level of care that you are billing for Medicaid. And we've got some really great contacts here. If you have questions about licensing and certification, you can email Sissy. And her email is here on the screen. And any ASAM implementation questions, you can feel free to email the SUD waiver project team as your main point of contact. So those emails are above. And again, copies of this presentation will be available after we adjourn today. All right. Some of y'all may have already seen this, but just a quick update. We did go ahead and refresh our medication assistant treatment or MAT list. It was updated in October of 2025, and it reflects the medications currently available to our fee-for-service OHP members. The goal, because it wasn't updated for quite a long time, is to stay up to date and accurate on this list as we move along through the SUD landscape. And the updated materials do include extra details on the medication that are covered, the associated rates, and how they appear on the behavioral fee health schedule. There's also reminders about the National Drug Code, or NDC, and their reporting requirements. So if you have any questions about the updates, again, the best point of reference for you is the medicaid.programs@oha.oregon.gov email. And I will drop into the chat the location of that document. Okay, great. So on to our next announcement. All right, a brief update on our current waiver. So the 1115 SUD waiver. We submitted the application to extend our existing waiver in March of 2025. The existing waiver period is set to expire March of 2026. Since then, we've had a regular cadence with our partners at CMS, which started in September of 2025 to review and discuss our extension requests. So the extension request includes two main components. One, we are asking to extend all current authorities that are already in place. And two, we are asking to add contingency management to our portfolio of services, which would expand the available supports for individuals with substance use disorders. We will be sharing additional details as the CMS discussions progress, but as of right now, we are still in active negotiations with CMS, so we'll keep you up to date on that. And then we have this exciting announcement. We have a monthly webinar for our new fee-for-service providers that started in January of 2026. This is every second Wednesday of the month from 10 to 11 a.m. Pacific time. And the training covers the OHP provider resources website, billing through the web portal, checking eligibility, and the steps to receive payment. This webinar is a great opportunity to ask questions, to learn essential tools, and build confidence when working with OHA. And to attend, it's really easy. Just email provider training-medicaid@oha.oregon.gov. So next month, as we were speaking about David coming in and doing such a lovely ICOD presentation, we were able to secure our culturally and linguistically specific services team as a special guest like David. So that will be very exciting and very cool. This is an amazing opportunity to learn more about their program, to ask questions, to engage with the team. There is a wonderful website that has a culturally and linguistically specific program and billing guide, and I will drop that in the chat. But next month, this will really be an opportunity for you to be able to engage with this amazing team, to learn about how you can become a culturally and linguistically specific service provider if you are interested. And also, if you're already a CLS provider, this is your opportunity to ask any questions about the program itself, about billing, about the mechanics, about policy. This is really your opportunity to be able to hang out with them and learn more about their wonderful program that reaches a lot of people in positive ways. All right. So we just really want to make sure, again, I know I talked about this prior, that everyone could get updates in the best way possible. So we are sharing our Provider Matters sign up and also our OHA distribution list sign up. Thank you, Sabrina. This way you don't miss any announcements. You're able to stay up to date on all of the latest and greatest from your team. And you can access, in particular, and I'll get to the next slide, the behavioral health updates through the distribution list this way. So you follow that link, and then you'll be given, once you register, a list of choices for your updates, and you could choose any of these behavioral health updates. And of course, you can go wild. You can, if you want to know everything about what's going on with OHA, you could probably sign up for everything and get emails all day. But we will leave that up to you. We just really want to encourage you to sign up for the behavioral health updates, and especially to get your SUD team updates, because we want to see you here every single time that we meet. All right. And I think I'm handing it over to Liz.
All right. Thank you. All right. Now we're going to get into some of the questions and answers that have come out of the feedback we've gotten and that we've just kind of seen coming through with our technical assistance questions that we are answering on an ongoing basis. And we wanted to bring up a couple of important topics here. Okay, let's just get right into it. Okay, first, I know everyone is waiting on, you can go to the next slide, the January 1st, 2026 rate changes that were mandated by CMS. They provide new relative value units, and we're going to have 3 SUD codes that are impacted by the rate changes. They are only the codes for telephone assessments, and we know at least that none of those rates are decreasing. We expect, those are going to be very modest increases as well. So we're going to get, the plan is to get a memo distributed and post the updated behavioral health fee schedule this week. So just asking for a little more patience on that one. And if you end up with questions, we can address those at our next technical assistance session on February 23rd. So just wanted to get that information out there so you know that it's coming and very soon. So, but again, only 3 of our codes are going to be impacted. So, and that's kind of the biggest, that's really the big fee schedule change for this month. We don't have other rate changes. We don't have significant changes of any kind really happening with the fee schedule right now, but we'll keep you posted. That's one of the reasons we hope that people will keep returning to this space, is we will continue to let you know as changes are coming out. If we make code deletions or additions, any price changes, those will all be discussed in these sessions. So keep showing up here. All right, and we can go on to the next thing. We're going to start getting into a little bit of the information from our surveys. Just again, I talked about this a little at our last session. There were a lot of different categories of questions, and we're going to be tackling these as we go throughout the year with these different sessions. We had ICOD, so we had co-occurring disorders, and we talked about that last time. We also got questions related to peer support services. So the plan is at some point to have a session with our subject matter experts in that area, and also some concerns about outreach billing, modifier usage, billable services, and just a very strong desire was reflected for general billing support. So that's what we are here for. And as we said last time, there were a range of questions related to CCO rates and billing, and sharing of challenges around that. And we can't directly address or help with those things right now, but just know we're hearing you, and there are some other avenues that you have, and you can definitely talk to the CCOs and things like that with rate questions. And if you're having issues, you can we can get you in touch with the right people to, if you need information about your account rep, things like that. But today we're going to tackle some of the remaining questions, billing questions from previous TA sessions. We've also had, like I said before, some general questions. So, and then there will definitely be some open time at the end for other questions. I'm sorry we didn't have that last time. David did such a great job with co-occurring disorders, and you had so many questions about that. And it was such a wonderful topic to have time for, that we ran out of time for open questions. And I want to make sure I know we all want to make sure that doesn't happen again, which is also why we lengthened the time here to an hour and a half, so that even if we don't need the full time, it's there, and we want you to feel like you have space to make inquiries of us, since we said that that's a whole goal here. So, all right, on to actual questions. Next slide. Thank you. Okay. So one of the big things I wanted to talk about first and foremost today was methadone billing. So we added code S0109 effective July 1st of 2025. And it's a code for 5 milligram doses of methadone. And it came to our attention that only one unit per billing line was being allowed. Oh, our slides disappeared. I don't know what happened. Oh no, I'm sorry. I clicked on a different tab. Wow, Zoom just did something crazy there. All right, I now have 2 tabs in Zoom. Sorry. That was a technical snafu on my part. I don't even know what I did. Okay, but I found you again, Jennifer. Okay. All right. So we learned that even if you were billing multiple units per line, you were being reimbursed for only 1 unit per billing line. So that has now been corrected in the system. You can now bill up to actually 999 units per line. And if you experienced an underpayment on your billing and you want to resubmit your billing, you can now do that. That has been corrected, effective back to 7/1/2025. So you should be able to proceed with that. And if you have any issues, you can work with provider services on that. And that kind of leads me into the next question, which was one that had come up in the previous survey, which was like, who can answer questions about how to expand billable services and what is or is not allowed in different settings? And then that kind of got me into wanting to also explain, as best I can, a little bit of the difference between like when you go to provider services and when you go to Medicaid programs, because I know we kind of give you these 2 different resources, and you might be sitting there going, well, who do I reach out to? And here is, now, frankly, like if you have a billing question and you reach out to Medicaid programs, they're going to reach out to analysts, and they will probably find the right person to help you with that billing inquiry. But I will say, if you are having a question or problem directly associated with a claim, provider services is really the ones that can dig into it first, and they will help you with, how the billing detail is getting entered. They can assist you with denials and prior submissions and things like that. So they're really your claims specialists as far as dealing with issues in the moment in the claims, that type of thing. Now, Medicaid programs, they can definitely handle policy questions. Your concerns about, something not being available as a billable service. They can also get you the information about, if you're saying, oh, here's this code and I'm not sure what I can, do with it, or what's, what this is used for, what services are included. That's Medicaid programs. They'll get you to the right analyst, and get some additional information to you that way. So you can kind of get those broader billing questions answered that aren't necessarily specific to a claim. And they're also kind of they're a better contact for questions about, if someone is qualified to provide a service, things like that. If you're sitting there saying, well, here I am, an SUD program, and I have this person, and I'm wondering if they're qualified to do this, particular thing. That's more of a Medicaid programs question, and we can find the right analyst for you. Now, keep in mind that at times, responses to those inquiries can take multiple days and even sometimes a number of weeks. Sometimes it takes a little time for them to get to the right analyst, and for that analyst to do the background research to make sure that we get you the right answer. Usually once it gets to us, if we do need to do background research, you will get an email, some kind of contact that says, hey, this question has come to me and I'm doing some research into it on your behalf. I'll reach out, as I get more information. So please be patient with that. But that's kind of the difference. I hope that that's somewhat clear. And I will pause now to see if anybody has questions about either methadone or, how to use those two different contacts. So I'll give it just a moment. All right. Great. If no one has questions, I will move on to another specific. Oh, yeah. When you're doing the take-home doses, yes, you can bill them on one day. That's fine. You can bill them on one line. That's great. Yeah. We want to make it easy. We don't want to, we realize you get 18 cents per unit on methadone, and we want to make the billing easy for you so that you're not having to enter a million lines of billing and make it complicated to where you have to try to spread it across multiple days or anything like that. We're trying to make this as easy as possible for you. All right. All right. If there's no other questions on that, then I will move on to another question that came out of provider registration questions when we were initially doing some of that survey. One of the questions that came up was how many services can be billed in one day? And we don't have a specific limit. And just want to make that clear. There's not going to be like a cutoff that says, no, you can't do that anymore. But it's up to you to provide the documentation to show that it meets the requirements for billings. And this is where I say, if you're trying to fill out a claim, it could be helpful to contact provider services. And I added their number to our slide there, but and maybe Sabrina can pop that in the chat. Actually, I'd appreciate that. And you have to make sure that we can't tell you how to bill for services, or what to bill, but you have to make those decisions and then be able to support them with the documentation. So that's the only caveat that we kind of give to that. We're not going to limit how many things you can bill in a day. And then another question that had come up was how and who to bill for SUD claims, like whether billing OHA or managed Medicaid, which I assume CCOs. Oh, and that question about, well, it's a good timing actually for the CCO question. Like, are CCOs required to cover the S010109? No, I mean, that's a code that we are we've made available, and they can choose to reimburse for that code, but it is not something that we can make them pay for as it's on our fee for service schedule now though, and hopefully that will encourage use. But everything that we talk about really relates to fee for service billing and billing for open card members. So hopefully that clarifies that. And so that's kind of what I'm getting to with this OHA or managed Medicaid. Like when you bill for services rendered to our open card enrolled members, you will be billing the Oregon Health Authority and working with us if there are any billing issues. If the member is enrolled in a CCO, then your billing is going to go through that organization and billing issues will have to be handled directly with them. And if you need assistance, getting in touch with an account representative, things like that, we can help you in that regard, but we just can't help you with the billing issue itself. So just want to make that clear for everybody. All right, next slide. A few more billing questions. This one actually Jennifer really already covered. And this had been in our last session, but I just wanted to kind of keep awareness on this with this new providers training series. I actually went to the first one, and it was enlightening for me, learning some things about the letters that you get and how you have to log in with your PIN within 90 days of that letter, or else lots of issues can develop when you go to try to do your first billing and you haven't initially logged in with that PIN and it expires. And so there were a lot of technicalities discussed of just kind of from the ground up getting going. And I know that there are going to be additional sessions that are going to keep addressing more and more as you go. So if anybody here is a newer provider, it could be a useful series to get involved with. And I have a feeling they're going to keep the trainings will keep building on themselves. So it's worth tuning in. I know I plan to be at the next one, continuing to learn more about how this whole thing works for all of you. And hopefully that will make us more useful to you if we're kind of seeing what you're going through as providers with all of this. So learning about the portal, things like that. So I hope everybody can make it to those. All right. And I guess my question got repeated on 2 slides. I apologize. That was me. All right. So the next question I already dealt with. Okay. And then something that's come up multiple times is people ask about what is included in the SUD residential rates, the H0018 and the H0019. And I just want to have a chance to put it out there for everyone what we understand as being included in those residential rates so that we can make sure that you understand that. So assessments, reassessments, UAs are a part of that. Now this is the collecting of the UA, of course, not the laboratory testing part of it. That happens in a laboratory. Individual therapy, group therapy, family therapy, oral medications, and medication administration or observation. The medication administration observation, but not the medications themselves. The medications can be billed separately, and there are a range of things that you can actually bill outside of the residential rate. So that includes transportation, translation services, acupuncture, peer services that reach in to help facilitate a transition out of the residential care. Employment, housing, to help with, again, transitioning out of residential care. Mental health services and supports can also be billed separately. Physical health services and supports are also billed separately. Medications, pharmacy, methadone would be billed separately, all of those kinds of things. Care coordination to help with transition at discharge can also be billed separately. And so one of the questions, for example, that came up for technical assistance was, can you bill care coordination on the same day that you're still billing, say, the last day of someone's residential stay or something like that? And absolutely. We talked about that with the program folks. If you are doing care coordination in aid of transitioning that person out of the residential facility, that is fine. Also, case management. Now, not covered by Medicaid would be room and board, which we say very clearly in the fee schedule. And one thing that was a reminder given to us is that individuals can use their SNAP benefits to cover the cost of meals and snacks. The Behavioral Health Division also helps pay for other room and board items for certain Medicaid individuals. And they have direct contracts with providers and counties and things to do that. But generally speaking, room and board is not a part of that. And there may be other avenues, though. If you need help finding any resources for that, you can let us know and we can try to point you in the right direction. So any questions on that, on the residential rates? All right. Okay. All right. I think we can do the next slide. Okay. Before I open up the floor to additional questions, I just wanted to kind of touch on some of the topics that we're going to get into in the future. We're going to be discussing rendering provider types allowed for SUD services and billing for SUD and mental health diagnosis on the same day. Those are going to be a couple of topics that are going to be worked into a couple of sessions in the future. But we really want to know what services you most struggle with billing like accurately and appropriately. What do you have the most questions on? What are you having? Where are you finding that you also might like to see additional, you know, opportunities? Like, are there services you want to learn more about? That's where CLS services coming next month is a great opportunity for anybody who doesn't know much about that program. So we want to encourage you to contact us with questions and topic suggestions. And if there are just things that you're feeling like you're not seeing covered and you really want to see discussed, reach out and tell us, and we would be happy to bring it up. And if we need to get a subject matter expert in the room, we will do so. Excuse me. I think my voice is giving out a little. Okay. And next slide. This is where I want to give everybody an opportunity where we didn't have time last session to ask questions or raise any concerns or offer any input on what you would like to see in these sessions, or what would be more helpful to you, or if there are things that you are not getting answers to that you would like us to bring up. So this is a chance for an open forum. And you can go to the next slide, Jen. Yay. And the email address is still there too. And if we don't have questions, we will definitely end early, but I want to give everybody, we have a chat question. Let me see. Okay. Thank you. All right. Suggestions coming through. And I don't know the answer on the assessments. I would have to find out more about that.
And we've got an ICOD question. I don't know if David is with us, but I know that he has a couple
I'm with
things
you in
going on
spirit.
today. Are you with us? We've summoned him.
I'm with you in spirit, but I don't know how closely I was able to. So I was multitasking a bunch of things, but
It's in the chat. It's in the chat.
It's written.
So yeah, because there was also a question about assessment that I was trying to catch up on. What?
Oh, all right. Yes, if you know the answer to that,
Let
please.
me change my eye gear. So what was the question about assessment? Firstly,
How
how often can we
often?
bill for assessments? Is there a limit, one per year, or any other limits or parameters we should be aware of? Yeah, it's a little bit different. So there is a project that I'm involved with around assessment and possibly doing the assessment in two parts, which you will be able to see on the outpatient rule, the 309, 019, 0140, I believe, or 0135. And the same guide that's been there for a while would apply to maybe multiple assessments, which is that we really shouldn't be doing another assessment unless there's a clinical change, like if there was a change in diagnosis or um, a change in level of care. That would be something that would create a new assessment. The thing that we were working on or been working on with the two-part assessment would actually be two different distinct activities, which were not, I don't mean to foreshadow and use people, which is what I'm probably doing, because we're still in process of working that out. But at this point, you could theoretically do a level of care assessment and a treatment planning assessment in two separate visits. But that's per the rule. Am I confusing things, Jen and Liz? I probably am.
Oh, that's perfect.
Yeah, that
Okay.
sounds like great.
And then the other question here about are CCOs required to pay the 20% ICD rate increase for master level providers and all the codes on the ICD billing guide? Care organisms pay the 10% or the 20% ICD rate increase when master level providers use the HO modifier on H005 or H0038, but they do for other codes like H0004. Okay, so first to be clear that you can't really use the ICD, and this might be a foregone conclusion, but just want to be sure. The ICOD modifiers can only be used by programs that are validated as ICOD providers by OHA ICOD and practitioners, so clinicians that are and peers and LMPs that are working within an organization that have been approved by that organization to be ICOD providers. So those are the two things that would need to be in place. And then within that, the 20% rate increase for master level providers, necessarily on all codes. So it looks like what this person's saying here in the chat is the HO modifier on 805, 8038. So a master's level provider would be billing 80038. 80038 is a peer service, right? So what are the chances of here being using HO modifier? I guess I'm asking a question about that. So that because I don't think that would happen very often, but I guess it could, and a CCO could have latitude on that because H038 is a peer service. So they would have the capacity to opt not to pay an HO on that, but they should pay an HH.
So
Go ahead.
we do have like master level therapists that are also CADCs, and they'll do the groups for H0005, but we're not getting any ICD rate increase when we bill those providers with the HO modifier for like H0005 or H0038. Are those providers not
I'm not
supposed
surprised that you wouldn't get it for H038. I don't think that doesn't. You shouldn't get it for that.
like we should not have those providers doing that service?
Well, I don't know if you shouldn't, but I don't know why you would. So, I mean, do you have do you have master's level providers that are peers that are doing peer service?
Not frequently, but every once in a while they would.
Do you have a master level provider that is a credentialed peer?
Yeah, like they would cover when the other peer support people were out.
Okay, so they should not bill that as a peer service. They should bill that so I'm more concerned about the H005. But that would be something to talk about with the CCO. Have you asked the CCO about it?
Yeah, for a few years now.
What do they say?
They will ask their claims department.
Okay. Send us an email on ICOD support. Could you?
Yes,
So
I can.
ICOD.support. Okay. That just kind of outlines what the challenge is.
Yes, I'll do.
Okay. Thanks. Did I do okay with that, Jen and Liz?
You were
Or am I
awesome.
over the okay?
Yeah, you're amazing. Thank you.
I'm so glad you're here. Thank you. Right. And then I see Lisa's comment about the 10.2% increase for SUD in 2026. Just wondering who issued the memo? Just trying to get a little more background on that one because I'm not sure what to say on that.
My boss got it, and he wanted me to contact DMAP and ask about it. And actually, we contacted Pacific Source last week, and they were like, "Well, we've not heard about that." And so he's asked me to contact DMAP, and then I seen there was a meeting today, so I was like, I'll just see if I can check here."
Yeah. And I'm not sure because I don't think that memo came from OHA. But I would be very interested in seeing the source of that so that
Okay.
we could get you some information because without seeing the memo itself or knowing exactly who it came from, I don't have an answer for that at this moment. And DMAP might tell you the same thing.
Okay.
Because they're going to
I'll
want to
try
know the source of it too. Yeah,
Right. I'll see if I can get it and maybe email it to you.
that'd be great.
Yeah, that'd be
Perfect.
amazing. Thank you.
We can connect you with the right people to help with that. So absolutely.
Perfect. Thank you.
Okay. Okay, and then I see a question from Vanessa about billing for case management under H0006 and has a maximum of 2 units. Units billed over 2 units will deny. Okay. And use T for each every person, no matter how many units are built. Is there a reason why? That one, I feel like I would need to get some more information to, I think our program folks might be able to help let us know if there's a reason for that limitation.
Yeah, we could check into it and see if there is actually a reason for it or if it's a technical snafu. And we appreciate you raising these types of concerns because as I talked about earlier, we've been able to knock out some of the errors through these questions and these inquiries. So thank you for raising that, Vanessa.
Absolutely, absolutely. Like the methadone issue. We had no idea until providers started saying, hey, we're only getting 18 cents, even if I build 42 units on a line or whatever. So it was not until your awareness that we became able to help. So thank you. All right. Any other questions, chat, or you're welcome to come off mute and ask questions as well. Oh,
So I have a question on behalf of a program that I met with earlier who actually has a representative here in this room. So it's interesting. Hi, Yolanda. I'm calling you on. So the program that Yolanda works with earlier was asking about UAs, and this is a question I told them I would bring to you two. So because I don't know the answer, which is, and I know you were talking about UAs a little bit earlier, so I might have missed part of that because of my multitasking. But the question was, and Yolanda, you tell me if I got this wrong, that if a peer were to do the collection activity and observation around a UA, and they do the clinical note and have the supervisor approve the note, is that an acceptable process to bill for the UA observation and collection code? Or do they need to have, is it not okay for a peer to do that? And I don't know the answer to that.
That's a really great question. And I actually think I may have already answered that, but I don't have it in front of me. So Yolanda, could you drop your email into the chat and then I can copy you and David on that?
Thanks, Jen.
We've had a lot of questions come up recently around UAs, so great timing on that. All right. All right. And then I see Philip dropped a question into the chat as well. Coverage here. Okay. That one I don't know how to question or how to answer. So we would definitely have to follow up on that one. Unless anybody else has any information, that one's not. But we are happy to carry that question forward and see what information we can get you for either who to talk to or an answer. All right. Any other questions? Can you hear
I'm
me?
sorry, I had to run and answer the door. I didn't see if anybody got my question
No
answered.
problem. I was just saying that's actually one I need to find the information for you. That's not one I know how to answer off the top of my head, but we can get you connected to either the right, someone else, the right person to talk to, or get you an answer to the question. So that's just going to take a little bit of follow up on our side. So I thank you for bringing the question forward, but we'll have to get back to you on that one because I don't know the answer off the top of my head. And I don't think anybody else here right now can respond to that one. Unless somebody wants to chime in. All right.
So I have a follow-up, sorry, about assessments. I'm emailing somebody and they're asking me. So I know that you said if there is a change of diagnosis or level of care, and they're wanting to know, like, I think this is a high example, but what if they had 5 level of cares or 5 diagnosis changes within a year? Would we be able to bill like 5 assessments, or would it be like a lower, maybe a one-on-one brief per session? Or is there a limit if those changes do occur? Does that make sense?
It makes sense theoretically, but I just I mean, I'm also and been a while, but I've used to work in organizations as a program manager and a counselor, SUD settings. I 5 levels of care in 1 year. Wow, that would be.
Yeah.
I don't know if there's 5 levels of care.
Right. I think I think it's a
2,
total
3.
exaggeration, but
I mean, right?
yeah.
So I think what happens, and I mean, this is my own editorial, but I think what happens sometimes when we get into these kinds of discussions is that we end up trying to play out like these theoretical scenarios that actually don't ever happen. So I don't think that you would ever have 5 levels of care in 1 year. But I think the point of the question is is there a limit? And I think that I would be speaking out of turn if I answer that question, because I think that Jen and Liz would have a closer to the answer than me, but I don't think they know exactly either. But I don't want to speak for them. Do you all know if there's a number?
I don't know if there's an exact number, but I think that clinical appropriateness would be the answer. I'd have to look closer at rule to see if we do get into the specifics on that. But I think that the key is clinical appropriateness.
Okay. Thank you.
Yeah, and Don had in the chat. I mean, yeah, a person can go back and forth several times a year. Yeah, that's true. I wonder how. I mean, maybe that is a realistic scenario. Yeah.
Yeah, and I think it also came up that if a patient like discharged for a couple months and then came back within that year, we would do a new assessment on them. So it could potentially be, and we do have people that, will drop out for a month or 2 and come back. So it could potentially, I guess, get more than, 2 or 3.
Yeah, and actually, if somebody is discharged and they come back, that is actually in the rule that you do a new assessment, right? So that's that was one of the first findings I ever got as a program director. was not doing that. So, I remember it well. But because if a person is discharged and closed, they come back into services, then you need to do a new assessment. Now, what we've done with the rule more recently, about a little over a year ago, is we've been able to create a pathway to use previous assessments to inform your new assessment, but you're still doing a new assessment because you're opening the chart again. You're opening the person again in your services.
Perfect. Thank you.
Okay, And I see the question about, we have a QMHP who is occasionally assisting our SUD providers with group sessions. Is our QMHP able to bill the SUD H0005 code? Okay, group counseling. David?
I mean, so is this the same person who was asking the question before about H05?
No.
Okay, because I was thinking about that after that interchange, because H05, my understanding was, correct me if I'm wrong, is usually a mental health group. No, I'm sorry, I am wrong. It's an SUD group. But traditionally, you can't really. I think what happens, because this is a co-occurring kind of a space, that you may not have, and again, Liz, correct me if I'm wrong on this one, that H05 is typically an SUD specific service, and therefore that service would need to be provided by somebody who is credentialed as a CADC or equivalent. If they're not credentialed as a SUD provider, but they're a master's level provider, or they're not credentialed as an SUD provider, that claim may be rejected because it's an SUD service. So an SUD, I don't know, for those of you that were at the ICOD meeting last month, you have to have so like the slot machine. I'm a gambling counselor too, so you have the slot machine has to line up. All of it has to line up, right? So if you have an A005, you should have an SUD credential provider providing that service with an SUD diagnosis in the primary spot. If you don't have those three lined up, you have a chance of having that claim denied, I would think. So if the person's a QMHP, but they're not a credentialed SUD provider, and they're doing an SUD group and billing it through H005 with an SUD diagnosis, it's probably going to get rejected.
Yeah, because they're probably going to have to bill it as a mental health provider, and then that's not going to fit with what it takes to bill for an SUD code.
Yeah, that's
So
my
you
understanding.
have to be eligible to bill as the SUD. Yeah, it has to have all, like David said, have all those things line up. So, and that's where we want to.
Questions.
It is a great question.
These are great questions.
I'm loving this because this also tells me why we need to discuss the topic of rendering provider types for SUD in a future session too, and do some background work on that, so we can bring forward some good information, because I think that that's something that obviously everybody wants to see. So,
a bunch of hearts going on there, yeah.
Yes, I'm seeing a lot of big support for that. So yes, so it sounds like we need to put together very soon a future topic on the rendering provider types and getting some clarity around all of that. So, all right, we're gonna put that as a top thing for for either, maybe not the next session because we're gonna have
March,
but I think
March or April.
I think that'd be a good
probably
March.
April. Yeah,
Maybe April. Yeah, that's true.
I don't know. We'll make sure, we want to make sure that we have the best content and the best documentation, because I think we need documentation to support that too, so y'all can walk away with something tangible.
That's a good point. We need a little bit of time to put that together. And our March session is going to be a week. Instead of being the fourth Monday, it will actually be the third Monday. So we'll have a little more of a shortened up window. That fourth Monday is spring break. And I will actually be out of the office, and Jennifer will also be out of the office.
I'm sure many other folks will be out of the office.
Exactly.
So we were like, bad timing.
Yeah, not the best week. So we're moving it up a week, and then our April session will be back at the normal fourth Monday. May will also be moved up a week because we figured you didn't want to spend Memorial Day here with us doing an SUD technical assistance session. So we'll do that one a week early as well. And then the rest of the sessions will be the fourth Mondays, 1:30 to 3. We're trying to allow plenty of time so that if we run a little over 2:30, we're not panicking and running out of time to answer questions and get your feedback. So yeah, just kind of wanting to do my little quick pitch for a moment on, please come to future sessions. And if there are any issues around attendance due to like time and date, like if it's just consistently a bad date and time for some reason, something, we'll keep that in mind. But we're trying to sort of create a consistent space where everybody can show up and be here. So, all right. And looks like another comment. All right.
I think that's just expanding off of
Yeah,
more
Emily gave
that
some
David was
additional info.
discussing. So,
All right. Any other questions? Anything at all? All right. All right. Well, I think if that's it for questions, we can actually call it early. But everybody can definitely email our SUD waiver email, obviously with ICOD questions. David has provided that ICOD support email address if you have ICOD specific questions. But please feel free to reach out to us too if you have topic suggestions and if there's something you really, really want to know more about. And if it relates to rendering provider types, feel free to ask us those specific questions as well, because we'll be working on that. So
yeah. Yeah. And again, do not hesitate to let us know what's working and what's not, what you'd like to see from us. I want to thank Sabrina, David, Liz, everyone for being here. I really appreciate coming together in community, and these engagements mean a lot. We very much so value what you do, what you provide to Oregonians, and want to make sure that we're supporting you in the best way possible. So hoping that your whole week is kind and lovely, and please do not hesitate to reach out to us anytime.
definitely.
Great.
Thank you.
Everyone say goodbye.
Thank you.
Bye, everyone.
Bye.